Selective serotonin reuptake inhibitors. For the purpose of this video, we'll only be covering SSRIs, but it is important to acknowledge that there is 5 major classes of antidepressants. While all classes of antidepressants are generally considered to be equally effective, they can have different safety profiles. The other 4 major classes are SNRIs, TCAs, monoamine oxidase inhibitors, and atypical antidepressants. Since SSRIs are a class of antidepressants, it is important to understand that the monoamine theory of depression is one of the most widely accepted theories, and it's used to explain the cause of depression, which states that it's caused to a deficiency of monoamine neurotransmitters, especially serotonin and norepinephrine. So when we look at the mechanism of action of selective serotonin reuptake inhibitors, we know that the purpose is to increase the available amount of serotonin. So if we look at this picture, we see that there is a presynaptic neuron right here, and we see that there is a postsynaptic neuron right here. These vesicles contain serotonin, and when serotonin reaches the cell membrane right here, it is released into what is called the synaptic cleft or synaptic gap, and then it is able to bind to the postsynaptic neuron with receptors of 5-HT. And there's multiple receptors for serotonin. We were not going to get into that during this lecture, but it is important just to know. So what selective serotonin reuptake inhibitors do is they basically inhibit SERT. So SERT is right here, and it is responsible for bringing back the serotonin into the presynaptic neuron. So SSRIs block this, so basically there's more free-floating serotonin. And SSRIs are selective, so they do act primarily on serotonin levels. And then we're going to get into the medication shortly. That brings us to our first question. Where is serotonin produced? Is it produced in the gastrointestinal tract? Is it produced in the locus coeruleus? Or is it produced in the raphe nuclei? If you answered C, raphe nuclei, you would be correct. SSRIs clinical management, they are first-line treatment for major depressive disorder. Why are they the first line in comparison to the other classes of antidepressants? It's because they have a safer side effect profile. So, what do SSRIs treat? Well, they are effective in a wide range of diagnoses, including bulimia, generalized anxiety disorder, obsessive compulsive disorder, post-traumatic stress disorder, social phobia, panic disorder, and premenstrual dysphoric disorder. Something that's really important in the clinical sense when you're educating patients about these medications, it's important to educate them that it can take 4 to 6 weeks for these medications to reach therapeutic effect. So typically on an exam, you may see a patient just started Zoloft 2 weeks after starting the medication. They're calling the practice because they said the medication is not effective at all. What would you do? Would you discontinue the medication? No. You would continue the medication and provide education that this medication does not reach therapeutic effect for 4 to 6 weeks. Another education point for patients is that once started on this medication, you're going to typically be on this medication for at least 6 to 12 months. Another high yield test question is antidepressants can actually induce mania in patients with bipolar disorder. So it's really important to get the right diagnoses. Otherwise, you can push a depressed bipolar patient into mania. All antidepressants have a black box warning for suicidality in children and young adults. What are the side effects of these medications? One of the primary reasons why patients stop taking these medications is because of the sexual dysfunction that is associated. It is estimated in 50 to 80% of patients taking these medications, people are unable to have orgasms, decreased libido. This is really a high yield thing. One of the medications that you can go on if you are having this issue with SSRIs is an atypical antidepressant called Wellbutrin, which does not have the sexual dysfunction that is associated with SSRIs. GI issues as well, 90% of serotonin is in the gut. So nausea, diarrhea, dyspepsia, anorexia, vomiting. This is the highest risk in Zoloft, okay? So we usually educate patients that are taking Zoloft to take it with food because that actually helps with the discomfort. Weight gain, this occurs in 1/3 of patients. Paroxetine has the greatest risk of weight gain. Cardiovascular wise, all SSRIs lengthen the QTC interval. However, Celexa or citalopram has the greatest risk. The FDA even recommends no longer prescribing greater than 40 milligrams of citalopram because of it. Headaches, the incidence is in 18 to 20%. Fluoxetine is the most likely to cause the headaches. Insomnia, the incidence is in 25%. Fluoxetine is also most likely to cause insomnia. So you would give this in the morning. Emotional blunting, so emotional numbness, is very frequent and underreported. It makes it difficult for these patients to feel emotions or even express emotions. Seizures, this is rare, 0.1 to 0.2%. And hematological side effects, very important with SSRIs. You need to know that they do increase the risk of bleeding. So special monitoring with patients with aspirin and anticoagulants and NSAIDs. SIADH, hyponatremia, increased prolactin levels, inducing mania, as we spoke about previously. And then two really high yield things that you'll always see is discontinuation syndrome and serotonin syndrome. We're going to talk about discontinuation syndrome in another slide, and I'll have a subsequent video just on serotonin syndrome. This is a psychiatric emergency, but you do need to know that SSRIs do contribute to this. When we talk about SSRIs, we have to talk about drug interactions. All SSRIs inhibit CYP2D6. This is super important because when you inhibit cytochrome P450 enzymes in the liver that metabolize many other drugs, this inhibition can increase the concentration of other drugs in the blood, which can increase the likelihood or severity of interactions. So SSRIs being inhibitors that prevent CYP450 enzymes from working, which decrease drug metabolism and increases the potential for toxicity of those other drugs that are being co-administered with the SSRIs. But it is important to note that different SSRIs have different inhibitory profiles. As shown, fluvoxamine has the highest inhibition of multiple CYP enzymes as listed, and then paroxetine and fluoxetine also cause major drug interactions, while Zoloft is a moderate inhibitor of CYP2D6, and the safest in terms of drug reactions are escitalopram and citalopram. You want to take that into consideration. If a patient is on multiple medications, will they interact with the SSRI that you're prescribing? And you also want to take into consideration certain classes of medications such as TCAs, beta blockers, other opioids, and migraine medication. All right, question time. As a provider, you have a patient who has been newly diagnosed with major depressive disorder and is currently taking several medications. You want to avoid prescribing a medication that inhibits the CYP450 enzyme. So which of the following medications would be the best choice for this patient? Would it be A, Zoloft, B, Lexapro, C, mirtazapine, or D, Luvox? And the answer is C, mirtazapine. It does not inhibit or induce any CYP450 enzymes. As we mentioned, all SSRIs inhibit CYP2D6. Next question. So a patient is taking tamoxifen to prevent the reoccurrence of breast cancer. She comes to your office for depression. Knowing that tamoxifen is a 2D6 substrate, which antidepressant would be appropriate? Would it be A, Wellbutrin, B, paroxetine, C, Cymbalta, or D, Effexor? The answer is D, Effexor. Wellbutrin, paroxetine, and Cymbalta are all 2D6 inhibitors, which would decrease the effectiveness of the tamoxifen. Serotonin discontinuation syndrome. As the name implies, it's a discontinuation, usually of the SSRIs or SNRIs, that contribute to this syndrome. So it's really important for SSRIs to be discontinued slowly to avoid discontinuation syndrome. A mnemonic for the clinical presentation is finish. So patients will present with flu-like symptoms, lethargy, chill, insomnia, nausea, vomiting, imbalance, dizziness, vertigo, sensory disturbances, shock-like sensations, and hyperarousal such as anxiety and irritation. Short half-life drugs are the biggest culprits of this, such as paroxetine and venlafaxine. I actually recently had a patient that called. They were on Effexor. They stopped their Effexor to go to a wedding for 5 days, and then they were all day in their bed Sunday because they had flu-like symptoms. Also, they also had nausea, vomiting, and they weren't able to keep any food down. Um, so they needed to start their Effexor back up. It's related to the sudden decrease in serotonin by not having the medication. So, risk factors are obviously abruptly discontinuing your medication, irregular patterns of taking your medication, being on long-term treatment with high doses. Question. So a patient has been treated with paroxetine for the past 3 years for major depressive disorder. The patient reports running out of the medication for the past 2 weeks, reports having flu-like symptoms, nausea, vomiting, and brain fog. What do you suspect? Is it A, EPS, B, neuromalignant syndrome, C, serotonin syndrome, or D, serotonin discontinuation syndrome? If you answered D, you answered correctly. Serotonin discontinuation syndrome. Citalopram Celexa. Starting dose is 20 milligrams for the first week and then usually increased to 40 milligrams. Common side effects are weight gain, sedation, agitation, yawning, GI disturbance, and sexual side effects. One thing to really know that they usually ask on tests that stands out among other SSRIs, it has the most profound effect on the QT interval in doses greater than 40. So yearly EKGs is usually recommended. While 20 milligrams a day in the elderly with hepatic impairment, CYP2, C19, poor metabolizers, patient 60 years and older, and patients on cimetidine. FDA approval for major depressive disorder, and it's used in adults only. Citalopram Lexapro, the dose is typically 10 to 20 milligrams a day. Common side effects is insomnia, headache, sexual dysfunction, and GI disturbance. Really big take home is that this is one of the cleanest and well tolerated SSRIs. The fewer side effects and drug to drug interactions. FDA approved for major depressive disorder age 12 plus and generalized anxiety disorder 7 plus. Fluvoxamine, Luvox. The dose is 100 to 300 milligrams per day. Important thing to note here is it is a potent inhibitor of CYP enzymes. We mentioned that's important because if it's a potent inhibitor of the CYP enzymes, it does have the ability to have many drug-to-drug interactions. Another really important thing to note is that it is the only SSRI not FDA approved for depression, but it is FDA approved for OCD, especially in children older than 8 years old. Paroxetine Paxil, the dose is 20 to 40 milligrams. As we noted previously, it has the shortest half-life of the SSRIs, making discontinuation syndrome very likely. So when discontinuing this SSRI, it may be helpful to actually pair it with a longer half-life medication such as fluoxetine when tapering it off. Not good for pregnancy. The FDA warned that Paxil medication increases the risk of congenital disabilities, specifically heart defects. So if you see a question on a test, which SSRI do you not use in a pregnant patient, it is always going to be Paxil because it is really contraindicated with patients that are pregnant. FDA approved for major depressive disorder, OCD, panic disorder, PTSD, generalized anxiety disorder, and social anxiety disorder. Fluoxetine Prozac, so typical dose is 20 to 80 milligrams daily, and you want to instruct patients to actually take this in the AM just because it does carry a higher risk of insomnia. The longest half-life is within this medication, so unlike Paxil, the discontinuation syndrome of this medication is actually unlikely. Side effects include insomnia, headache, nausea, and sexual dysfunction. One really important thing to note, it is actually the only SSRI that is approved for bulimia. So FDA approved for major depressive disorder, OCD, panic disorder, PTSD, premenstrual dysphoric disorder, treatment-resistant major depressive disorder, usually in combination with Zyprexa and bulimia. FDA approved in children for major depressive disorder greater than 8 and OCD greater than 7 years old. Sertraline, Zoloft, the dose is 50 to 200 milligrams, and you typically start at a dose of 50. Common side effects are GI disturbances, headache, and sexual dysfunction. Um, really want to focus on the GI disturbances. This is a typical medication you want to tell patients to take with a meal just to help with that stomach discomfort. One other thing I have seen on exams is that it is false positive for benzos in urine toxicology screen. So it can cause a false positive for those benzos. FDA approved for major depressive disorder, OCD, panic disorder, PTSD, premenstrual dysphoric disorder, and social anxiety disorder. FDA approval in pediatrics is OCD 6 years and older. We have reached the end, so let's just do a recap. SSRIs may take 4 to 6 weeks to reach their therapeutic effect. Antidepressants can trigger mania in patients with bipolar disorder. All antidepressants carry a black box warning for suicidality in children and young adults. Celexa has a profound effect on the QT interval at doses greater than 40. Celexa and Lexapro have the least drug-to-drug interactions. Fluoxetine is the only SSRI approved for bulimia and has the longest half-life, while paroxetine has the shortest half-life, making discontinuation syndrome likely and should be avoided during pregnancy. Zoloft may result in a false positive for benzodiazepines in urine toxicology screens. Higher GI disturbances with Zoloft and safer for pregnancy, which I didn't mention in the slide, but you should know that. Luvox is the only SSRI not FDA approved for depression, but it is approved for OCD. And then again, all SSRIs inhibit CYP2D6, paroxetine, fluvoxamine, and fluoxetine have the highest risk for drug-to-drug interactions. All right, thank you.